Hello, everyone. My name is Ann Clement, Global Marketing Communications Director at GE Healthcare, and we're delighted to have you join us today for our digital meetup, From Weeks to Hours, Accelerating Breast Cancer Care with One-Stop Clinics. And now I'm delighted to be able to introduce our moderator, Dr. Ben Anderson, Professor of Surgery and Global Health at the University of Washington, and the creator and chair of Breast Health Global Initiative, which pioneered the development of research-stratified guidelines for breast cancer early detection, diagnosis, treatment, and palliative care in low and middle income countries, among other appointments. And now we'll get started with Dr. Anderson.
Well, thank you, Ann, and I'd like to thank everybody for joining today's webinar for this One-Stop Club Breast Clinic discussion. Today, I am joined by a group of leading global breast cancer experts representing areas across the world to discuss their experience in developing one-stop breast clinics in their countries. Today, more than ever, we know that it's very difficult to get women to come in for breast imaging, whether it's related to screening or not. Of course, the pandemic has been very unhelpful, and now people are fearful of coming in, and therefore the efficiency with which we do this is quite important. If you take this one step further, once a woman learns that she has some suspicious finding on a mammogram, or if she notices a finding or lump in the breast, there's very significant anxiety that goes with this. Everyone who is involved in breast care is aware of that. And so being able to establish systems that are functional and meet her emotional as well as physical needs are very important. But the problem is daunting. Not everybody is ready to deal with this issue head on. As you know, by the time the patient has talked with a referring physician and scheduled a follow-up, significant time has passed. The anxiety is increasing on a daily basis, and this is really just a fundamental issue in breast cancer, whether one is in the United States or Europe or in sub-Saharan Africa. So all of this makes a lot of issues in terms of logistics, systems efficiencies, a lot of anxiety. These are issues that we all want to address. Today, we're going to talk with some of these leading experts in the field, and we're going to talk about how all of this works in these changes in rapid diagnosis. That's the goal. Before we dive in, let's please be aware of the Q&A widget that is available on your screen. Please use this for questions. We'll take the questions toward the end of today's discussion, and that's where we stand. So please note the Q&A widget. Let's get started. For the meetup, I'd like to start the discussion by telling you of my peers who are joining us. We have Dr. Suzette Delaloge from Gustave Roussy in France. We have Dr. Sebastian Diaz from Dynamica, SURA in Medellin, Colombia, and Dr. Joseph Russo from St. Luke's University Health Network in Bethlehem, Pennsylvania in the United States. Dr. Delaloge is a medical oncologist who initiated this approach. Dr. Diaz is a surgeon, and Dr. Russo is a breast imager. We're going to be talking about three primary topics. The first is the potential benefit of implementing one-stop clinics. Why now? Why do this? Then the second question, how the one-stop breast clinic can reduce time to diagnosis and improve outcomes. And then finally, how is this model different from other types of one-stop activities? Dr. Delaloge, you are the head of the breast clinic at Gustave Roussy. You're the founder of this. Thank you so much for joining us today.
Thank you very much. Thank you for inviting me.
Great pleasure. Dr. Diaz from Medellin, you run the One-Stop Clinic in Colombia. We're very much looking forward to hearing from you about how this clinic has impacted on your practice in Colombia. Welcome.
Hi, thank you so much for the invitation.
And finally, Dr. Russo from St. Luke's in Bethlehem, Pennsylvania. You're the section head of the women's imaging at St. Luke's and has also been heavily involved in this programmatic development here in the United States. Dr. Delaloge, I'd like to provide the first question to you. How did you come up with the idea of developing this first one-stop clinic in France? What did it take to start this? How did you engage with this? And please give us an overview of how this has helped you address the healthcare pathway in your comment. Dr. Delaloge?
Yeah, thank you very much. Indeed, this was kind of a long time ago, in 2003, or almost 20 years ago. And at that time, France was about, for the first time, to launch a generalized organized screening all over the country, which did not exist before. So this generalized screening for breast cancer was launched January 1st, 2004. And at that time, the access to diagnosis was very difficult. Even in my institution, I work in a big comprehensive cancer center, and even at our place, it was kind of difficult to have a rapid access to diagnosis. And moreover, the pathway beyond diagnosis was a bit complicated. Namely, community doctors had to take an appointment at the center for a first visit. Then the patients were to come back after this first visit for a biopsy, whatever the type of biopsy we needed, and then they had to come back with the result. And overall, it took a long time. And we had epidemiological assessments in France, and especially in Paris suburbs, showing that the median time for getting between the mammogram and getting a proper diagnosis, whether it was benign or malignant, was around 60 days, which is a very, very long delay indeed in diagnosis. So we decided to organize ourselves to provide the best ever quality diagnosis, because it had to be very rapid. It had to suffer absolutely no delays. It had to be organized, and the most important thing was that given the recently launched standards that were published, I think, around that time by ZOMA, etc., it had to be multidisciplinary. So we decided to organize this all together, and we brought together radiologists, pathologists, surgeons, medical oncologists, and in this very moving field of breast cancer, where the role of surgeons, medical oncologists, plastic surgeons, pathologists, etc., and biologists, together with the radiologists, is so important, where multidisciplinarity is so crucial. We decided to create this one-stop unit, where women from the community who had an abnormal finding, either clinical or on mammogram, were referred for one-stop diagnosis. And we decided that the time interval between the screening mammogram and our first appointment had to be very short, around at most 2 weeks, and we wanted to have a target around 10 days, if possible, for a median time interval. And we decided that we should make all efforts to be able to provide women with benign images, with a benign diagnosis on one day, because, well, this is one of the things that is also a problem with screening, is the false positive findings and all the worries of all these women. And moreover, and probably most importantly, for women with breast cancer, we thought it was very important that they could have the diagnosis in the shortest term possible. And not only the diagnosis, because it's difficult to face a diagnosis, but we thought that facing diagnosis with a treatment plan all together, all wrapped in with all specialists, was something very important. So I think this is how we came to this, and indeed it was very, very transformative in the field. And now we are in 2020. In our hospital, we have other short-term and one-stop diagnosis for other aspects, and I think all the oncology fields right now is moving towards short-term diagnosis very broadly, because we know that if screening is important, it's also part of this importance is because you are able to provide people with short-term diagnosis and care and treatment. So that's for the story. Thank you very much.
Well, so thank you very much. That certainly the goals of this are everyone would agree, are very important and valuable. And what you're telling us is that there's a technical component to this and a coordination part, and that you need to have multidisciplinary team involvement. So we'll get into the details of this in a little bit. Dr. Diaz, you're in Medellin, Colombia. For those who don't know, Colombia is an upper middle income country in Latin America. And I gather that you developed this model under the advice of our colleagues at Gustave Roussy. Could you tell us, how is this, what we just heard from Dr. Delaloge, how is this similar and is it different in Colombia in comparison to the issues that you've been addressing? Dr. Diaz?
Yes, it's a history that comes from maybe 2010 when we first look at what was our real numbers, and when we got a suspect of some symptoms in the breast. Until you get a diagnosis, the time that we measured was very, very long, maybe 6 months to get a diagnosis. So then we changed back in maybe 2014, and we created a women's clinic, no one-stop clinic, a women's clinic that maybe organized a little bit that diagnostic and all the exams that the people that the patients have to get done. And we're much better than before because we reduced that day in 35 days to get a diagnostic, but we were not that. So that's why we took a little bit of some exchange of information, and then we received the Gustave Roussy One-Stop Clinic with General Electric, and then we introduced in Medellin with very good results. Now we are in 18 days to get a diagnosis. We are measuring everything, and the results are great. So we're very happy with it.
Well, that is very exciting to hear about, and I'm pleased to hear that has gone well for you. Dr. Russo, my understanding is that you are in the middle of setting up this one-stop clinic based here in the United States. And our colleagues have talked about having a 20-year and 10-year involvement. As someone who's doing this more recently, could you please tell us how is this going for you, and why is this particularly a good time to be doing this here in the United States?
Well, thank you. In truth, the goals of the Gustave Roussy Clinic we've been trying to do at St. Luke's University Health Network for some time now, and that's a truly patient-centered process where we basically try and get the screening mammograms done at about 20 screening sites now, done as locally and quickly as possible. But anytime a woman needs that second-level screening or the diagnostic workup, we've been trying to consolidate all of that work into one regional breast center here in Center Valley, Pennsylvania. Invariably, anytime I tell a patient that she needs a biopsy, the first question they would ask is, well, when can we do this? Hoping for as soon as possible. And with that thought in mind is how we really developed our systems here. And the number one thing we did to make that happen is to really consolidate our resources, both radiologists, technologists, nurses, under this one roof here. And what it allowed us to do is have the ability to offer that same day biopsy service to patients, because I think once a woman has that callback or that recommendation for a biopsy, the same day biopsy is really the most valuable thing you could do for an anxious patient. So one of the reasons we found this project so interesting is I think GE is really looking to quantify and characterize ways that we can make this process available as a template for any breast imaging program. And we'd like to see it implemented on many days as possible at all those breast imaging programs. So I think the data should be interesting to look at.
So could you comment then, Dr. Russo, on you're talking about implementing this on days of the week. It sounds like a component of this implementation has to do with your organization and clinical scheduling, that you're doing something different from just saying, hey, we've got a slot, let's put the patient in for a diagnosis. Could you say something about how that organizational structure is a component of this?
Well, the goal should be to offer the same-day clinic to the patients that have the highest likelihood of requiring biopsy. Okay, so as a case in point, you can schedule all of your palpable lump patients in the mornings of your same-day clinic days. Therefore, if a biopsy is necessary, they can be added on throughout the course of the day as you go. Things like 6-month follow-ups for breast patients would be less integral to have on the same day clinic days at your facility because they are most often benign and continue to follow up. But it's really scheduling the highest risk patients, or the patients with the highest probability of requiring a biopsy on those on the one-day clinic days. If you have the personnel to do it, there really is no reason you can't do it every day, but often getting enough radiologists, breast imagers under one roof the same day, as well as the nurses and the support staff for biopsies, not every place has that ability. So, we could understand if you were only doing that schedule for 1, 2, or 3 days a week.
I see. So what you're saying is that part of the system organization is that you have to, as the imaging group, preview who's coming in, what the likelihood of they're going to need a biopsy is, and then you stratify in some way, selecting some patients for this clinic, others not necessarily because the likelihood of biopsy is going to be low. That's very important. Dr. Diaz, you've heard about the description. You're a surgeon. So surgeons are commonly presented with palpable findings or clinical findings as opposed to being a recipient of someone undergoing screening. Could you say something about the impact on the patient and what your experience has been with this in terms of helping patients with their anxiety and about how it's helped you in the overall clinic experience for the patients? Can you comment on that, please?
Yes, of course. The one-stop clinic for us is great. I think for everyone, having a one-day diagnostic for breast imaging and breast biopsies is great for us, like physicians, because in the same day we got all the information that we need. We got all the images that we need. We got the same day result of the biopsy. We got a clinical exam for the patient. Then we got a radiologist helping us doing everything, and then the pathologist. So I think the difference here is that we got everything. The difference that we got with other clinics and the things that we got before is because when you got a lump, and it's a palpable lump, and you can a biopsy the palpable mass and then take biopsy. But if the biopsy you are not able to get a mammogram, not able to get an ultrasound, and you're not able to get that same day result, so you get nothing. So the patients have to come once again, and you have to ask another exams. So that fragmentation means time for the patients, that means time for us, and means time for everyone, and everything it's just going to take more days than actually you're just doing everything in one day. So I think having a one-stop clinic, having the multidisciplinary team, that's not your only view. You have the view of the surgeon, but you also have the eyes of radiologists. You also have the concept of the pathologist, that it's taking you a different view of everything. And I think that's the main goal and the main winning that you got. And the patient have everything in one day. So the patient doesn't have to move, doesn't have to have permissions to move to get an exam from place. So I think everything here in One-Stop Clinic is a win-win, and for us.
So thank you, Dr. Diaz. Your video is frozen for just a moment. Thank you. That really makes a lot of sense. Dr. Delaloge, I'd like to come back to you now. You founded this approach. We've been talking about the rationale and of the same-day evaluation, rapid diagnosis. We've talked about the benefits for the patient. Could you talk about it from a technical perspective? As you conceived of this, what are the technical aspects of the approaches to the imaging and sampling that are different from what had been done before, or what might be done in clinics other than your own? Can you comment on that, please?
Yeah, sure. I think it's indeed a very important aspect is that if we want to go to earlier and earlier detection, I think we aim to this, and it's well, earlier detection is something that we have been living for years, and it's improving all the time. We have to face more and more complex lesions, and I think the workout we can provide in this one-stop clinic has kind of changed over the 17 years period during which we have used this approach. And right now we are seeing very complex lesions, and well, it's a bias, but a lot of patients are referred to us for this. And I think the level of expertise that we can have together is very high. And not only because we have very, very good radiologists and because they get trained to seeing very complex lesions, etc., but because the technologies are moving all the time, and these radiologists can all at a point use the best ever available technology. And there are also some algorithms they need to know very well, build themselves indeed, and follow. So I think there is some kind of complexity of the lesions we find. The algorithm we described that really is something, well, that is perfectly addressed by this kind of multidisciplinary clinic. And I think the multidisciplinarity is very important because well, first of all, the initial images are watched together by the clinicians and the radiologist, and sometimes the pathologist is already there. We do decide together what we need to do to have the perfect workup. For example, we will choose if additional tomosynthesis is required. We use a lot of CSM for dense breast or for suspicions of multifocality. We use it also to decrease the number of required biopsies, but sometimes also to identify multifocality. And so there is a planning that is done together, and I think this step is already very important. And the radiologists really appreciate to know what are the goals of the care of a woman. If it's an 80-year-old lady with a big lump that looks unique, and this woman is already decided for a mastectomy, I think having complex assessments is not so important. We need a unique biopsy, etc., and we will be able to assess the axilla. But for a young woman, well, for whom the question of preserving the breast or not preserving, making sure there is no additional suspect lesion, making sure what is the landscape in both breasts, I think this the added value is very important. So I think that kind of clinic needs to integrate the best up-to-date technology in terms of imaging, but also, of course, in terms of clinical assessments in terms of vision already from the diagnosis of what can be proposed to a patient to cure her at best if she has a cancer, and at the meantime to have the less sequelae possible. And for example, we will already have an assessment of whether a conservative surgery is possible, or whether if we do a mastectomy, we can do an immediate reconstruction, which we do most of the time. And if there is an immediate reconstruction, whether we can do preservation of the areola. So that's very important. We need to integrate. It's patient-centered, but it's also very technical with the integration of all the needs, the requirements, and the algorithm from the pathologist, from the surgeons, from the medical oncologist, and of course of the radiologist to provide the patient with the best expert diagnosis and treatment plan. I think that's absolutely crucial.
So you've made the strong argument that this is a multidisciplinary approach. You're actually thinking ahead to the cancer treatment and identifying how you can coordinate with the clinicians that are going to be managing that. Of course, very important. And you talked about using imaging techniques. Could you say something about the tissue sampling? Do you use core needle biopsy? Do you use fine needle aspiration? And how does that impact on this this approach?
Yeah, of course. So there are different techniques that you can use in order to provide a one-day diagnosis. There are different techniques, but not that many. The fastest technique is to use FNA, fine needle aspiration. With fine needle aspiration, you will be able to know there is a well-known classification. You'll be able to know whether it's a carcinoma, if it's a tumor but not carcinoma, which is the rarest thing ever, but this exists. If it's an intermediate lesion, suspicion of atypical lesion, or if it's perfectly benign and you can identify some of the different benign lesions. Beyond that, using FNA, you will be able to get ER, PR, and HER2, but not on one day, so it's not, something you absolutely need. But this is limited, of course. You will not have the full profile of the tumor, etc. You will be able to have an FNA performed for the axilla also, if there is a suspicious lymph node. So I think FNA is very practical and very relevant and much easier than biopsy for the axilla in case of suspicious node. So that's important. So what we do use is FNA in most of the cases for lumps, of course, not for microcalcifications, and for suspicious nodes, so that we have an immediate diagnosis that is accurate for lumps in almost 90% of the cases. But this is not enough, of course. So for most cases, not for all the benign, but for all cancer cases, we do the biopsy at the meantime, and we know that we will have a refinement of the full diagnosis within 2 or 3 days. So we can, with the clinical presentation, radiological presentation, workup that we have, if it's a tumor that is less than 15 millimeters, unique, etc., we can already plan the surgery. If it's a lesion that is more than 2 centimeters, we already can orient to the potentiality of neoadjuvant therapy, and it's going to be different according to age, etc. And this we will be able to refine after a few days with the full histological diagnosis. This material that we harvest could also be used for rapid techniques of PCR, etc., but this is costly and not so quick. So the last thing you could use to have a rapid diagnosis, you can use FNA for one stop. You can use some techniques of a rapid PCR, but it lasts a minimum of 4 to 5 hours. And you can use a technique of a rapid biopsy, but once again, this means that you have all your biopsies already done at 10 a.m. and you will have all the full results with the immunohistochemistry around 5 p.m. So that's very difficult. So clearly we use one-stop FNA with the results provided on one day, and it's already very helpful. A lot of women can be reassured that they don't have cancer but benign lesions. Women know whether they have a cancer. If it's a multifocal cancer, we can just do one biopsy and have FNA on the others. They know whether there is an axillary involvement, etc. And we can already have a lot of information towards planification. And then there will, in case of cancer, we will have more information and see them again to refine all what we have said before.
Well, that's just fascinating. And what you've said is that you're actually using fine needle aspiration in the great majority of your cases. You probably know that in the United States, fine needle aspiration is not used in a large number of centers. It's actually, we went through a period where there was a debate about FNA versus core needle biopsy. Yeah. You're talking about the strength of FNA being you can get nearly immediate reads versus core biopsy where it has to sit in fixative overnight. But it also sounds like you're using FNA in a triage fashion. You talked about clearly benign versus indeterminate versus malignant. So it sounds like FNA is a sort of a triage approach. One of these criticisms is that you need to have a cytologist who's comfortable reading fine needle aspiration of the breast, and a breast histopathologist may not be comfortable doing FNA. I would venture to say most of them are not. So how have you overcome that cytologic expertise issue, or how have you managed that in the context of your clinic in France?
Yeah, there are two parts. Indeed, the problem with the FNA is that if the aspiration is done by a radiologist or a clinician who is not well trained or very well trained, the first problem is that like at least 40% of the samples will not be relevant. There will be no diagnosis. So that's a huge problem. So what we do in our clinic is that the sampling is done by the pathologist herself. Well, it's a girl. We just have girls. So the cytopathologist herself, and under the guidance of the radiologist. So the radiologist that does the ultrasound, and the cytopathologist that does the sampling and verifies it immediately. So we know it's a good sampling, and it's a forehand, so it's much easier. So when we have the radiologist do it, the success is clearly poorer. We have trained radiologists who can clearly do it, but the success is poorer. So that's one aspect, is how to harvest the FNA. The second aspect is reading FNA. And indeed, it's not easy for a standard, well-trained pathologist that only does histology. It takes around 1 year to be absolutely confident, because you need confidence. Providing one-stop diagnosis means you really need to be confident to be sure what you say, and it's not so easy. So so we have a lot of quality controls, of course. It's very clear that when you do this in a multidisciplinary team, the quality is very different if as compared to a cytopathologist reading somewhere in a lab something that has been harvested by a radiologist in another place, another day. So I think the multidisciplinary aspect is probably very important. Probably because we influence each other, but not only, I mean, in terms of, and also of training, I think that's very important. So these are two different aspects, but you are absolutely right. You need trained pathologists and trained cytopathologists. So, and in our team, so it's a bit special because they are the ones doing the sampling once again. And so it's not so obvious to find pathologists who want to do the sampling. So if you don't have these persons, you need to have radiologists who are well trained to sampling themselves. So it's a bit challenging, yeah.
So when you say that when we talk about same day, for those that are not familiar with fine needle aspiration, it's a technique where you obtain cells, you smear them out on a slide, you can read them immediately. So different from a core biopsy, you have to wait for processing. And that's why the person doing the sampling is also, you need to have someone who can look at the slides at the same time to decide if it's adequate or decide if you're going to get more cells at the same time. Is there any difference between the efficiency or effectiveness of doing a fine needle aspiration of cancers versus benign masses? Getting cells out of a fibroadenoma can be kind of tricky. So what about benign versus malignant, given that most masses are actually benign?
Yeah, indeed, our positive predictive value is currently around 97 to 98%, and the negative predictive value is even higher. No, it's the opposite. Sorry, I'm mistaken. Sorry. The positive predictive value is very, very high. Our specificity is very, very, very high, and the sensitivity is almost as high. The sensitivity we have is around 97 to 98%, which is the equivalent of ultrasound-guided biopsy in standard conditions, let's say. It's not absolutely perfect, so we know that we may miss 2% of the cancers. So we are aware of this, and we have algorithms in which we rebiopsy in case it's a benign lesion and it's discordant. So when it's a BI-RAD 4B or more, we do, of course, have a biopsy on top of the FNA. So FNA is mostly a triage thing, as you mentioned. It's very helpful for women in terms of having their diagnosis done one-stop. But it's just an aspect of the one-stop clinic. You can have a one-stop clinic without having FNA because there are many other aspects that are of great interest, as we mentioned before. But anyway, what you need is to have very clear-cut algorithm on what you want to do, what you need to do in this situation, and what to do if this biopsy has a positive or negative result, etc. So that's something very difficult and tricky with breast imaging, breast biopsy, and breast sampling, etc. Is that it's a complex field, and you need to have very highly trained people, and it's very dependent on this. So people talking together, the confrontation of the image versus the result, it has to be absolutely in line, etc., etc. And last thing about fibromas or fibroadenomas is that for most of them you also need a biopsy to make sure that it's not a phalloid tumor, of course, even a benign one. So you need a lot of biopsies indeed. Yeah.
That's an excellent point. Dr. Russo, you've heard the description about how this was originally developed, and clearly they have a highly evolved program that they developed over 20 years at Gustave Roussy. How has this worked in your center in Pennsylvania, and how have you addressed the cytology versus histology issues, and are there special issues or concerns that you've needed to overcome?
Well, there certainly were. I mean, the standard of care in the United States remains core biopsies. We're trying to do essentially a 36-hour turnaround from the time of diagnostic workup to pathology, and we're doing that pretty routinely. We're proud of it. There were some obstacles to overcome. In the past, a woman's breast health has largely in the United States been a a surgeon-directed process. So, for example, if a radiologist recommended a biopsy, those patients would often see a breast surgeon after that, at which point they might come back to the breast center for their biopsy. In the vast majority of the time, this was really just a time loss for the patient. So part of what we managed to achieve at St. Luke's was getting all of our surgeons on board with the fact that the same-day biopsy, or writing a script for diagnostic imaging plus biopsy if necessary, was really the most expedient way to treat their patients. Patient anxiety level decreases precipitously. Patient satisfaction obviously increases. And the surgeons get those patients once pathology is available, and the surgeons can do what they do, and we can do what we do. And it came to be a very streamlined process. But the fact of the matter is there are often some institutional changes that need to take place in order for this same day policy to happen.
Sure. So in the U.S., making the setup complete, not just in conversation between the radiologist and the clinician, but actually doing institutional arrangements so that this would be permitted and you could bill for it, but the goal being to do this immediately. What fraction of your biopsies are fine needle aspiration as an initial step, do you think? Have you brought FNA into the degree that we heard from Dr. Delaloge, or are you using more core needle biopsy than she described?
Well, Ben, as you stated earlier, I think in my experience and in the United States in general, FNA pathology for breast-related issues is something that a lot of pathologists aren't specifically or trained in high volume. So we exclusively use core biopsies. The thought of implementing FNA with a specially trained pathologist is a thought in a same-day clinic, but in coming up with a program that any breast center in the United States could adopt and implement, I think would require use of core biopsy samples at this point, practically speaking.
Well, there are a couple of centers in the U.S. that do the approach that's similar to what Dr. Delaloge talked about. UC San Francisco, for example, has heavily integrated this. There's a program in Boston that's similar, and University of Florida in Jacksonville. But you're right, it requires that special setup. And part of that is instead of seeing FNA versus core, it's how do we selectively use FNA in ways that make it expedient. And it sounds like a difference is you're not getting readings at the end of the day. Your goal is to get readings within 36 hours. Dr. Diaz, could you tell us how has this worked in Colombia? And how have you been integrating FNA versus core needle biopsy? And are there other aspects of this that we've talked about that might be different in your setting? Could you advise us?
Yes, of course. Before we heard about the One-Stop Clinic from Gustave Roussy, we were doing just like Dr. Russo just talked. We were doing a biopsy and then having the result 3 days or maybe 5 days with everything, with diagnostic and immunohistochemistry. But right now, the main aspect, I think, is the main issue too, is to get a cytologist and a pathologist that is comfortable doing cytology. I know that's the main issue, but that's, I think, also the main thing that you have here to win different in the other concept that we got before. Why is that? It's because you got a diagnostic in 1 day. So the same day you know that that patient have malignancy or not, and you're doing this winning 3 or 4 or 5 days after you got the diagnostic. That was the main change. It's still the main debate that we got in Colombia because, like the United States, in Colombia, cytology and pathologists that were comfortable doing cytology were very, very difficult to find. Then we have some pathologists comfortable doing it, like we started with one main pathologist that were comfortable doing it, and then we start training more pathologists that were comfortable doing cytologies, and the results that we got is great. Actually, we use FNA in every patient that comes to the One-Stop Clinic right now. We have numbers that we are doing just FNA in 48% of all the cases. So we're not doing core and FNA, just FNA to get a diagnostic, mainly when you got a fibroadenoma or a benign disease that you are comfortable just with the FNA. But when you got a suspect that you got a BI-RADS 4 or a 4B, 4C, or BI-RADS 5, and you got a diagnostic with the FNA that you got a cancer, so you already have information, and then you got also a core biopsy. We're not, when we got a positive cancer diagnostic, we're not just doing FNA. We're not doing immunohistochemistry in FNA. We're also complementing with core biopsy, and we got the results also 3 days with all the immunohistochemistry. But I think that the main thing that we got with the FNA is, like Dr. Delaloge told before, and it's like a triage. And maybe sometimes you're just comfortable with that triage. If you got a benign disease with FNA, maybe sometimes we're just comfortable with the FNA, maybe all the cases, but the only thing that we add a core biopsies when we got the feeling, the clinical issues that maybe you got a phyloid, but all the benign that we are diagnostic, we're just using FNA, and that's the main thing that we're winning here, and I know that it's the main issue. It's very hard. You get a breast surgeon, you get a radiologist easier than you can find a pathologist and a great cytologist that you're comfortable with the diagnostic and you're comfortable with that reading. That's the main issue that we also have here. But the thing that we're doing is just training them, and then you got a great one-stop clinic that you are comfortable doing it.
Well, that's really helpful. And what I'm hearing from all three of you is that actually whether the degree to which one uses FNA or core needle biopsy is something that one adjusts. False negatives occur in every setting, including core needle biopsy. So having that integrated clinical follow-up to make sure that the lesions that were initially read as benign, in fact, are behaving in the way that one would expect a benign lesion to be. And you really have to adapt to your environment and the resources that you've got. I think at this point, what I'd like to do, if we could, is let's open this up to questions for those who have posed them. And so I'd just like to remind everybody that you use the Q&A button that's available. I'm wondering, this goes to all three of you, how many patients can you manage in a day with the approach? Just if you could each give me an approximate number, and how different is this from before?
I'll be happy to start.
Sorry, please, Dr. Russo.
I think with the same-day clinic, our goal would be to have about 20 scheduled patients for the same-day process. Our current full diagnostic day is about 40 diagnostic patients. But if you were marketing that same-day service, you could obviously not do as many.
Very good. And how is that different for you, Dr. Diaz? How many patients are you managing in a day, and how different is it from before? I'm sorry, I think he's frozen again. Dr. Delaloge, how many patients are you managing in a day in your setting?
We currently do manage around 25 patients a day. It happened that we had more, like up to 35, but it's not feasible. So not that, now that I think legends for which patients are referred are more complex. So I think 20 to 25 is very, very feasible. More than 25 is difficult. You must double the number of physicians you have, etc.
Okay, that also is very helpful. In terms of the pathologists, did they have? You said that you need to find a pathologist that is comfortable. Do they require special training for this? Have you provided special training? Is there certification? How does that work in France?
So yes, in France we don't have many cytopathologists. It's a specialty that is decreasing as it is in the US. There are specific training, as I mentioned, they need around 1 year. So each of the pathologists who work with us are both cytopathologists and histopathologists. They do both, but and most of them do all types of cytopathology, including we do a lot of one-stop for thyroid lesions, for example. It's very convenient, but they also used to read pap smears. Also, there are less pap smears right now, and they do a lot of cytology for other purposes in oncology. There are many applications. So I think we have good pathologists, cytopathologists, but I think they need to get trained in an oncology center. And there are some board certifications regarding cytopathology. It's a subspecialization of pathology. There is an international society. There are conferences that provide education. There are recommendations for breast cytopathology, etc. That are last time they have been published, I think, 1 year ago, around, or it was in 2019, for instance. So there are a lot of things available. I think this field is still moving, clearly. The only thing I regret, and I have to say that I thought when we started that we would have a lot more molecular cytopathology in use after 20 years and available on a daily basis, etc. But this has not evolved that way, and it's not the fault of cytopathologists, but the role of biology at the initial diagnosis of breast cancer right now is still a bit limited. Beyond immunohistochemistry, there is a lot of genomics. We use a lot of genomics now in the metastatic setting, etc. We use genomic tests for deciding whether patients should receive chemo or not. But at the time of diagnosis, it's still quite limited. Otherwise, cytopathology is something that is very convenient. It can provide very good quality material, etc. So this is my main regret. I think this is, well, it might change in the next future when more targeted treatments will be available, etc.
Well, you might be interested to know that there actually is good work going on in Latin America and Sub-Saharan Africa using PCR technology combined with FNA that's proving to be quite effective and cost-effective. Could you say something about the tools that are used for the sampling? One of our questions had to do with, is this FNA guided by palpation? Is it FNA guided by ultrasound? Is it stereotactic? When you're doing FNA, how do you aim the needle and how do you image the breast to know that what you sampled? Perhaps could you comment on that, Suzanne, briefly? And I'd like to hear how Dr. Diaz has done that as well.
Yeah, sure. It's only ultrasound-guided FNA. That's the only way to do it. Well, we do not use clinically guided FNA anymore, not for the breast and the axilla. It could be used for palpable lesions of the skin in other instances, but it's only ultrasound-guided FNA right now. Yeah.
Very good. Dr. Diaz, how is the FNA sampling guided in your clinic?
Well, we also use only ultrasound-guided FNA. We are not using clinical palpation to take any samples. And the main difference that we use is that actually the radiologist is the one that is taking the sample, but with the pathologist inside. So it's both sample checking. The radiologist take the sample, give it to the same area, and they check. And if everything is okay, then the pathologist goes to reading. So that's maybe the main difference that I have heard from Dr. Delaloge. And the first question, we're actually using a double circuit. We're attending 17 patients in every circuit. So in one day, we're just diagnosing 34 patients every day into circuits, and that's only in Medellin because we're moving and starting the one-stop clinic in other cities in Colombia.
Wow, that's neat.
Wow.
Dr. Russo, we're getting a series of questions about insurance and about other types of imaging like tomography. Is insurance coverage an issue for you here in the US? And what about other imaging, MRI, for example? Does that play any role in this? Or are we really talking about the basics of ultrasound core needle biopsies?
Yeah, I mean, that would by far be the workhorse of the same-day clinic is ultrasound-guided cores. MRI, the MRI time is so valuable to a hospital that holding MRI slots for potential add-on biopsies isn't a real practical thing in the United States. Stereo would be available as well for stereotactic core biopsies. You know, one of the things that's important to talk about is the availability of the Fna cytologist as well. So for example, if an Fna cytologist is available 2 days a week, that's not much of a difference in turnaround time compared to a core needle biopsy being done every day of the week, right? So if a patient has to wait for those appointments on only 2 days a week, you're not really doing much for turnaround times unless they're luckily getting worked up on that same day the cytologist is there. So it's an important thing to consider because of the rarity of those cytopathologists in the US anyway also. Tomosynthesis is, that's still more of a screening tool, and we've seen similar improvements in the expected cancer detection rate. Typically, it goes up about 40 to 50% when you add 3D tomosynthesis to a breast screening program. But again, not really in the, that's really off topic for same-day discussions.
So we're just about out of time from our discussion. Dr. Delaloge, as the one who's had the longest experience from this, going back to the patient experience, have you had any oncopsychology involved in what you do? Do you have, I've seen some of your work, and I gather that patient navigation, patient navigators are part, but can you say something about how to help the patient go through the anxiety and challenge of this process?
Yeah, that's a very good point, obviously. There are many publications on short-term diagnosis that all clearly show that short-term, and especially one-stop, seems to be better tolerated by a patient finally, not only because they have a rapid diagnosis, but also because they stay a mean time of around 6 hours, 6-7 hours with us. They have time to know us. They know that everybody talks together, and it's a place that is not so bad, let's say. So I think the experience, and if it's a cancer diagnosis, the first experience is so important. The experience must be an important part of it. So we initially thought that it would be very important to have a psychologist on site, and at the end, we never need a psychologist on site. I mean, during 17 years, it happened like 5 times that we had to call the psychologist finally. Around 8% of the patients are over anxious, and so we just need to identify them as early as possible during the day. And we know that these people will hardly stand to wait too long, or the overstress, etc. So for these people, the nurse navigator will be very, very helpful. And we eventually will propose them to change the plans and come back in a few days if they don't want to spend too much time, etc. So I think trying, either you use a questionnaire or you use human intuition, trying to identify those people, those women who are very anxious at the beginning could be something useful. Beyond that, what is very important is communication, explanation, information. So each time they meet somebody during the day, this person introduces himself or herself, explain what he's or she's going to do, etc. And the women exactly know from the beginning, most of them are women indeed, what they will get, what is the pathway. And the nurse navigator is absolutely crucial so that we make sure that the pathway is respected, that the patient tolerates what's going on, that there is no pain, etc. So I think that aspect, and I think the nurse navigator is that the most important thing, and the human skills and the human expertise of this person and all people working there is very important, very, very important.
Well, thank you very much for that summary. I'm so afraid that we're out of time. We didn't even get a chance to talk about the impact of COVID-19 on all of this, but perhaps that should be for another time. Dr. Delaloge, Dr. Diaz, Dr. Russo, thank you for your time. Audience, thank you for your patience in our getting started. We greatly appreciate your time with this digital meetup, and we look forward to future opportunities to discuss the One-Stop Breast Clinic. Anne?
Great. And on behalf of everyone at GE Healthcare, I also want to thank all of our speakers, as well as you, Dr. Anderson, for moderating this digital meetup. We will be posting a replay of this scientific exchange in the coming days, and we encourage you to share that with your peers. I also put on the screen some upcoming events starting next week, and hope that you'll be able to register and join us for those events. But again, thank you to all of you very, very much for joining us today and for this very, very interesting and captivating discussion on the One-Stop Clinic and how it can really help improve outcomes. And with that, I'd like to say good afternoon and good evening to everybody, and hope to speak with you again soon.
Thank you.
Thank you to all. Have a good day.
Thank you.
Bye-bye. Bye-bye, everybody.
Bye.
Thank you so much. Bye.